الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين وعلى آله وصحبه أجمعين. Nutrition Second Lecture by Professor Mahmoud Hani Sulaiman. Assessment of nutritional status of a community, food balance sheet, dietary survey, and nutritional survey. Food balance sheet assumes equal food distribution and calculate food per capita per day from each of 11 food groups. It equals produced زائد imported per year minus exported زائد agriculture and industrial use divided by mid-year population multiplied by 365 days of the year. Advantage of food balance sheet: demonstrate dietary composition and increase or decrease of use, compare years and countries. Disadvantage: assume equal food distribution, but there is difference by sex and age and so on. Continued food balance sheet. Egyptian diet as studied by this method. 200 extra calories deposited as fat will lead to increased weight in Egypt is more than in Sweden. B2 intake is decreased. Vitamin B2 intake is decreased. R-riboflavinols is common. Cereals, main dietary source, 500 calories. Diet adequate in quantity and inadequate in quality. This lead to hypoproteinemia due to decreased biological value proteins in the foods, leading to Egyptian height less than Sweden height. Fish should be source of protein because it is of low cost and contains high biological value protein. Dietary survey to compare food intake with that consumed really equal food per week. This is called dietary survey. Tells us the quantity, types, family survey, individual survey, institutional survey. Diet planning. For construction and selection of adequate, well-balanced diets, taking the following in consideration. How to calculate energy production. 1 milligram fat is giving 9 calories, 1 gram protein or carbohydrate giving 4 calories. Factors affecting caloric needs. Reference man. E.g. university student, age 25. These are the specifications of reference man. Age 25, male 6, weight 65 kilogram, work 8 hours per day, environmental temperature around him is 10 degrees centigrade, health needs are 3000 calories. Reference woman as reference man, but the weight is 55 kilogram, need 2200 calories, add 550 calorie per day during pregnancy and lactation respectively. Quantitative planning, e.g. for reference man. Protein 1 gram per kilogram per day, 1 multiplied by 65 multiplied by 4 equals 260 calories, 10% of calorie per day. Fats is equal 20% of calories per day. Carbohydrate equal 70% calories per day. Vitamin, mineral, trace elements, water, all of them must be present. Nutritional problems in Egypt. Some of them. This figure I tried to summarize the Egyptian malnutrition. In infants and preschool, as you see, protein calorie malnutrition, anemia and rickets. In school children, as you see, The most common is hypoproteinemia, anemia, and riboflavinosis, undernutrition, dental caries. Less common, avitaminosis A, endemic goiter in oasis. In pregnant lactating women, add school as these two and add osteomalacia, maternal depletion syndrome, composed of osteomalacia, hypoproteinemia, iron deficiency anemia. Among adults, as school as this, but no undernutrition because excess 200 extra calories. Again, Egyptian malnutrition among infants and preschool, school, pregnant and lactating adults. Infants and preschool, protein calorie malnutrition, anemia, and rickets. In school, common hypoproteinemia, anemia, riboflavinosis, undernutrition, and dental caries. Less common, avitaminosis A, endemic goiter in oasis. Among pregnant women as school, but add osteomalacia, maternal depletion syndrome, which is osteomalacia, hypoproteinemia, and iron deficiency anemia. Among adults as school, but no undernutrition because excess 200 extra calories. Causes and predisposing factors of malnutritional disease. Causes and predisposing factors of malnutritional disease, which equals factors affecting nutritional situation in different communities. These are primary factors, secondary factors, and relative malnutrition and specific factors. Primary factors. Dietary deficiency error due to low socioeconomic standard, which will lead to poverty, decreased income, wars, famines, disaster, unemployment, increased fertility. Low socioeconomic standard due to poverty, decreased income, wars, famines, disaster, unemployment, and increased fertility. Lack of nutritional education and defective food habits. Primary factors, either low socioeconomic standard and lack of nutritional education and defective food habits. Secondary factors, interfering with digestion, absorption, utilization of nutrients, or causing loss of nutrients. These are either parasitism, gastroenteritis, avitaminosis, malabsorption syndrome, and liver cirrhosis. Parasitism, gastroenteritis, antivitaminosis, malabsorption syndrome, and liver cirrhosis. Relative malnutrition due to negligence of increased nutritional needs during different physiological states as growth, pregnancy, and lactation. Factors altering the dietary requirement of nutrients are biochemical individuality, gender, lactation, infection, surgery, smoking, caffeine, activity, genetic differences, pregnancy, growth, other disease, drug-nutrient interaction, alcohol, environmental pollutants, exercise level. Specific factors. Kwashiorkor, repeated pregnancy will lead to sudden weaning on starchy or sugary foods lacking in proteins. This leads to decrease in high biological value animal proteins. Hypoproteinemia, acute due to severe hemorrhage or burns, chronic due to inadequate protein intake. Some Egyptian nutritional problems. Obesity, we have mentioned it before in the lecture 1. Anemia and rickets. Anemia, iron deficiency anemia caused by low fetal stores of iron born to anemic mothers. This equals 20% of cases. Lack of milk supplementation with iron from external sources. It should begin at 5 to 6 months of age. Phytates and phosphates in cereals hindering iron absorption, rural areas. Failure of reduction into ferrous state due to decrease in vitamin C, hydrogen chloride, gastric acidity or proteins reducing agents. Chronic blood loss bilharzia, ankylostoma, malaria, piles, etc. Prevalence of any kind of anemia among children and adolescents aged 5 to 19 years in Egypt. As you see, among females, the prevalence of anemia is about 21%. Among males, it is about 70%. Facts about anemia. In developing countries, every second pregnant woman and about 70% of preschool children are estimated to be anemic. Anemia is aggravated by infectious diseases like worm infestations, malaria, HIV, and tuberculosis. The major health consequences include poor pregnancy outcome, impaired physical and cognitive development, increased risk of morbidity in children, and reduced work productivity. Anemia contributes to 20% of all maternal deaths. About 1/5 of all maternal deaths are due to anemia. Consequences of anemia. General, it will lead to weakness, easy fatigability, lethargy, inhibition of lymphocyte proliferation, lower cell-mediated immunity, reduced neutrophil bactericidal activity, vulnerability to infections, diminished physical and earning capacity, reduced work capacity, reduced endurance. Pregnant and lactating women, the consequences may be weakness, diminished physical and mental capacity, increased morbidity from infectious disease, increased risk of low birth baby, abortion, premature delivery, intrauterine growth retardation, congenital fetal malformation, maternal mortality. Children, low birth weight, perinatal mortality, impaired cognitive performance, motor development and scholastic achievement, psychological and behavioral effects like inattention, fatigue, and insecurity. According to age, anemia definition changes. As you see, here is the age group and here is the hemoglobin threshold. Please print and use in examination of your patients. Iron deficiency anemia, microcytic hypochromic anemia. Definition: a microcytic anemia, small, pale red blood cells and depletion of iron stores. The hematocrit is less than 41% in males and hemoglobin less than 30.5 gram per deciliter. In females, hematocrit less than 37%, hemoglobin less than 12. Incidence: iron deficiency is the most common cause of anemia worldwide. It is particularly prevalent in females in childbearing age. About 48% of premenopausal young women are iron deficient. It is estimated to occur in 1/5 of adult women, 1/2 of pregnant women, 3% of adult males, yet does not commonly transpire in absence of bleeding. Pathogenesis. Anemia is acquired. It develops slowly and in stages. Iron loss exceeds intake so that stored iron is progressively depleted. So, compensatory increase in absorption of dietary iron and in concentration of transferrin occurs. Iron storage can no longer meet needs of erythroid marrow, plasma transferring level increase, and serum iron concentration decrease, leading to decreased iron available for RBCs formation. Predisposing factors: female with heavy menses, chronic blood loss, family history, poor diet, excessive cow milk intake, closely spaced pregnancies, lactation, chronic hemoglobinuria, chronic aspirin use, repeated blood donation, decrease in iron absorption, taking too much antacid, post-gastric bypass surgery, GIT diseases, chronic kidney diseases. All these are predisposing factors for iron deficiency anemia. Common complaints: fatigued all the time, heart feels like it is racing, beating hard, out of breath on exertion, loss of appetite, nausea and vomiting, headaches throughout the day, weak and dizzy. Rickets originate from decreased vitamin D or decreased calcium due to low fetal stores of vitamin D born to osteomalacic mothers, lack of milk supplementation with vitamin D from external sources, lack of ultraviolet rays, poor housing, indoor life, dusty atmosphere, wrapping infants. Prevention of malnutritional diseases. Prevention of primary malnutritional diseases, socioeconomic development, industrialization, family planning and inter-pregnancy spacing, proper antenatal care by adequate diet, vitamin, minerals given free at MCH centers, nutritional education to population in MCH centers and school girls because they are the future mothers. Prevention of secondary malnutrition disease, mainly parasitism, prevention of parasitism and chronic communicable disease as tuberculosis. Prevention of tertiary malnutrition diseases by increased nutritional intake according to different physiological states. Prevention of specific factors for malnutrition disease, kwashiorkor, anemia, and rickets. For kwashiorkor, proper weaning on animal proteins, e.g. sopamine, anemia, supply of iron, vitamin C, protein, milk supplementation with iron, prevention of parasitism, and prevention of bleeding states. Rickets, milk supplementation with vitamin D and exposure to sun. وفي النهاية أقول الحمد لله و thank you for your good listening.